In this section, we're going to discuss progressive multiple sclerosis. My panel members today are Dr. Mary Rensel, Dr. Devon Conway, and Dr. Daniel Ontaneda from the Mellen Center for Multiple Sclerosis. Dr. Ontaneda will talk to us about progressive MS, and then we'll discuss.
Thanks, Alex, so much for that introduction. Today, I'm going to be discussing the best practices for progressive multiple sclerosis and expert recommendations based on abstracts from the Consortium of Multiple Sclerosis Centers meetings in Dallas. I want to start off with discussing this abstract, which is the characteristics of disease progression in secondary progressive MS. This was a research study conducted through the North American Research Committee in MS, or NARCOM's, Registry Research Group. It included a total of 5,452 patients who have been followed in the NARCOM's database for 5 years, from 2006 until 2010. Patients were classified into low disability, those with a patient-determined disease step lower than 3, and those of high disability with a patient-determined disease steps greater than 4. Different predictors were analyzed to look for those at high risk of disability. And what the authors found was that male gender, older age at time of diagnosis, longer MS disease duration, and a higher patient-determined disease step at baseline predicted greater worsening in mobility, hand, vision, and bladder and bowel functions. The practical points is that high disability predicts greater worsening in MS patients. The classical risk factors, including age, gender, and longer disease duration, once again were shown to predict outcome in this database. And this data highlights the importance of early and complete control of disease activity in patients with relapsing MS who may go on to develop secondary progressive multiple sclerosis. I want to ask how this study will influence your current practice. It will not change your practice at all, or 100 with an absolutely change in my practice. The second abstract I wanted to discuss was the use of lithium for progressive multiple sclerosis. This research was presented by Dr. John Rinker from the University of Alabama in Birmingham and the VA Medical Center of Birmingham. It was a study that enrolled 23 subjects. It was a crossover study of 1 year duration. The median EDSS at study entry was 4.0. 87.5% of the patients had secondary progressive MS, and 12.5% of the patients had primary progressive MS. What the authors found was that there was 5 discontinuations from this trial. Initially, a dose of 600 milligrams of lithium was tried, but this dose then had to be reduced to 300 milligrams due to toxicity. There was 141 months of lithium exposure, and the medication was mostly well tolerated. The main adverse effects that were encountered were thirst, polyuria, and fatigue. I wanted to highlight this abstract because it is one of a growing number of research protocols in progressive MS looking at potentially neurotherapeutic agents that may provide a neuroprotective effect. Lithium is one of these and is being studied at a dose of 300 milligrams a day, and at that dose it seems to be well tolerated. Efficacy data was not presented during this abstract, but will be presented at the time of study completion. Side effects may limit the feasibility in a larger study, and there was a relatively high dropout rate. There was also concerns that lithium may potentially deteriorate gait, and this may be a deterrent for a phase 3 study. Once again, I want to ask how this will influence your current practice. 0, it will not change my practice at all, or 100, it absolutely will change my practice. Physical activity is something that in multiple sclerosis patients who are wheelchair-bound sometimes we ignore. And this is an abstract that is focusing precisely on this group of patients. Dr. Learmonth from the University of Illinois at Urbana-Champaign did a qualitative research project where interviews were conducted with MS subjects who are wheelchair users. They determined the meaning of physical activity, exercise, the benefits of physical activity, and which facilitators occurred with physical activity. This research study is unique in that it was going into the patient's environment and it wasn't being studied in an outside clinic. This is something that is typical of qualitative research and probably gets better at how patients feel and function. The results show that many patients recognize the benefit of physical activity and exercise. But there are significant barriers, and these were identified in the study for patients to have physical activity when they are wheelchair users. That includes ongoing symptoms, strength problems, issues with mobility, lack of professional input. The conclusions of the authors is that intervention-based therapy should be used. The interventions and the physical activity should be symptom appropriate, and it should be conducted in an appropriate environment. The practical points is that I think that we should try to stress that physical activity and exercise is an important component even in our wheelchair-based patients. Exercise should be considered even outside ambulatory activities. Typically, when we recommend exercise, we ask patients to either walk or do some type of physical activity which requires ambulation. But there are activities which don't require ambulation, which should be practiced by these patients. Professional referrals are likely to be very helpful in getting these patients adequate exercise regimens and should be encouraged. Physical activity should be focused on symptoms which affect the patients and therefore provide a maximum benefit to them. Once again, will this study influence your current practice? 0, it will not change the practice at all. 100 absolutely will change my practice. The last abstract I wanted to discuss was social cognition decline in multiple sclerosis. This was research that was led by Andrea Tecchino from the Italian MS Society. It was an innovative design to measure social cognitive function in MS patients. They studied 14 patients with low EDSS, mean of 3, and then 6 patients with high EDSS. 17 healthy controls were also studied for comparison. And what the authors looked at is they were testing whether MS patients could discriminate between cooperative, competitive, or individual intent based on videos of specific tasks. Individual intent was either slow or fast, and that was compared against a cooperative and a competitive algorithm. And the data was then compared between MS severity and the healthy controls. What the study showed is that patients with MS, especially those with more advanced disease, develop social cognitive impairments which may affect caregivers and family. That is, the patients had difficulty recognizing the differences between cooperative and individual tasks. The identification of social cognitive impairment by practitioners may help guide treatment options in cases of social dysfunction. As we know, MS patients have significant cognitive limitations and also might have significant social problems related to lack of income, loss of family support, and therefore taking into account that the patient's perception of social cognition might be altered, might give some added insight into why they develop these problems. I would recommend prompt referral to health psychology to help patients and family understand social cognitive deficits, especially in patients with progressive MS. Once again, will this study influence your current practice? It will not change my practice. 0, absolutely will change my practice. 100.
Thanks, Dr. Ontaneda. I wanted to ask you a couple of follow-up questions. What do you think is the biggest challenge in improving therapeutics in the progressive MS population?
Thanks, Alex. That's a great question. Developing therapeutics in MS has been a significant challenge, especially in the progressive group. And to date, we really haven't identified a therapy that works on progressive MS. I think there's several challenges. One challenge is identifying molecules that target the disease. I think that significant work is being done currently in animal and benchtop models of the disease that will allow development of potential compounds can be tested. But I think that one of the bigger challenges is actually conducting trials that enable us to see if these medications make a difference. I think one of the biggest problems is that we don't really know how to measure progressive MS. I think studies like the one by Ticino and also the qualitative research provide an insight into what MS patients actually feel in their houses. Maybe we should be measuring stuff that's much closer to feeling and function, and that will allow for better trials. Additionally, there's a lot of advance in MRI measures, OCT measures, optical coherence tomography, which may allow more sensitive outcome markers in progressive MS. I think if we can improve the way we measure progressive MS, along with identification of novel molecules, we're on the right road to develop therapies for this form of the disease.
And one more follow-up question. The recently published reassessment of classification of multiple sclerosis, Dr. Loveland's panel, and they suggested adding active and progressive measures to the designation of primary and secondary progressive MS. Can you comment on that new idea?
Absolutely. Thanks, Alex. Yeah, that's another great question, and I think it ties very well into the question about clinical trials in multiple sclerosis. So I think that the revised definitions provide a person to have progressive MS with two different identifiers. One, if they're actively progressing or not, which can be the case or not, and then two, if they have any evidence of active inflammatory disease. I think that's very useful, one, for physicians when we're classifying progressive MS patients, but I think more importantly, for research studies. Because one of the big problems is that we might have been enrolling patients in progressive studies who have inflammatory disease activity. And looking at anti-inflammatory therapies, certainly there's going to be benefit in the inflammatory measures, but maybe not in the progressive MS measures. On the contrary, patients who aren't progressing have also been a problem in clinical trials. So if you enroll 1,000 patients into a trial, but it turns out that some of those patients aren't actually progressing, essentially you're underpowering your study because you're not going to be able to detect a difference. So I think that the new classification is definitely a step forward. It simplifies the way we view progressive MS, and it also provides a good standard for clinical trial work in the future.
Thanks, Dr. Ontaneda. In this section, we'll be talking about advances in care for neuromyelitis optica. Our panel are Dr. Daniel Ontaneda, Dr. Mary Rensel, and Dr. Devon Conway. And Dr. Devon Conway will lead the discussion.
Thanks, Alex. So I'll be going through some abstracts from the recent AAN meeting in Philadelphia. So we'll start with an abstract entitled The Revised Diagnostic Criteria for Neuromyelitis Optica Spectrum Disorders, which comes to us from Dr. Dean Wingerchuk and colleagues at the Mayo Clinic. The diagnostic criteria for NMO were last updated in 2006, whereas the concept of the NMO spectrum disorders was defined in 2007. So it was time for an update. The International Panel for NMO Diagnosis met 7 times between October 2011 and November 2013 to come up with these consensus criteria for diagnosis. What they decided to do was to incorporate all of these diseases into a single unified term called NMO spectrum disorder, and then to stratify those individuals by serostatus, either being positive or negative for the aquaporin 4 antibody. The group defined some core clinical characteristics for these patients, which include optic neuritis, acute myelitis, an area postrema syndrome, such as intractable vomiting, other brainstem syndromes, symptomatic narcolepsy or a diencephalic syndrome, and a symptomatic cerebral syndrome. If patients have the aquaporin 4 antibodies, then in order to meet criteria for NMO spectrum disorder, they need to have one or more of these core clinical characteristics. Patients who are negative for the aquaporin 4 antibodies need to have 2 or more of the core clinical characteristics, one of which must be optic neuritis, acute transverse myelitis, or an area postrema syndrome. Such patients also need to have MRI support, lesions that would be characteristic of NMO and not more suggestive of a different diagnosis such as multiple sclerosis. And they also need to demonstrate dissemination in space, so recurrent episodes of transverse myelitis would not qualify. So these revised criteria incorporate the new concept of NMO spectrum disorders, and they should improve care by making diagnosis easier. They also allow for future revisions, in particular if other autoantibodies are discovered that might explain some of the variation in NMO spectrum disorder phenotypes. So I'd like to know if this study will influence your current practice. Please rate between 0, no change, and absolute change. The next abstract that I'd like to discuss is called Autologous Hematopoietic Stem Cell Transplant in Neuromyelitis Optica. And this comes to us from Dr. Jodie Burton at the University of Calgary. This abstract reports on a clinical trial for which the key inclusion criteria are a diagnosis of NMO, age 18 to 65, treatment with an NMO therapy in the past 12 months, and at least one relapse in the last 12 months despite that treatment, and at least 2 relapses in the last 24 months. Patients were excluded if they had an illness that might compromise their ability to complete the study, or if they had a prior malignancy aside from something minor like a skin cancer, and if they had significant cardiac or pulmonary disease. The key outcomes for the study will include the proportion of relapse-free patients at 3 and 5 years, that's the primary outcome, the number of NMO relapses requiring rescue therapy, the time to the next relapse, and the time to a one-step increase in the EDSS. It's important to note that these patients underwent a transplant conditioning regimen, which included 4 cycles of cyclophosphamide and 1 dose of rituximab. Now, this is an early report on the study, and only 2 participants have been enrolled so far, but they do intend to enroll a total of 10 patients. The first patient has been followed for 3 years, and in the year immediately before treatment, that patient had 5 relapses, and in the 3 years after treatment, the patient has had no relapses. Similarly, the second patient had 4 relapses in the year before treatment and just 1 relapse in the 2 years after treatment. So based on this study, some stem cell transplantation appears promising, but we need to note that this is a very small sample size so far, and it's an uncontrolled study, so we really don't know how these patients would have done if they hadn't received the stem cell transplant. Also, some of the benefits that were observed might have been related to the cyclophosphamide or the rituximab that the patients were treated with. Again, I'd just like to know if this study will influence your current practice. Please rate between 0, no change, and 100, an absolute change. The next abstract to discuss is called The Therapeutic Effect of Plasma Exchange in Neuromyelitis Optica, Immediate and Long-Term Response. This abstract comes to us from Dr. Baha Nouri at the University of Toronto, and it was a retrospective study to look at the therapeutic effect of plasma exchange, 5 alternate day cycles, in patients who failed IV steroid treatment for an NMO relapse. They were able to find data on 40 patients at the time of their discharge after the relapse, and on 26 patients at 12 and 6 months after discharge. At the time of discharge, these patients were rated based on their functional improvement, either no improvement, which 35% of patients had, mild improvement was seen in 42% of patients, moderate improvement in 20%, and a marked improvement in 3%. The authors analyzed the available data to try to identify predictors that would help to decide what patients were most likely to benefit from PLEX. And the predictors that they identified were reflexes being present, either normal reflexes or brisk reflexes at the time of presentation, and in younger patients less than age 40 were more likely to benefit. The clinical status at 12 months after this plasma exchange, 7.6% of patients had worsened, 61.5% of patients had mild or no improvement, and 30.9% of patients had a moderate or a marked improvement. The only predictor that they were able to identify of this sustained improvement at 1 year was early PLEX, meaning within 25 days of the onset of the relapse. So this abstract adds to the literature supporting plasma exchange for steroid-unresponsive NMO relapses, and it indicates the importance of initiating PLEX early, particularly in younger patients with intact reflexes who might be the most likely to improve with plasma exchange. Again, will this study influence your current practice? Please rate between 0, will not change my practice, and 100, absolutely will change my practice. Our fourth study is another clinical trial, a trial of C1 esterase inhibitor in acute relapses of neuromyelitis optica. And this comes from Dr. Michael Levy and colleagues at Johns Hopkins University in Baltimore. So it's important to understand for this study that complement is believed to play a role in the immunopathogenesis of acute NMO relapses, and that C1 is part of the complement cascade, and that inhibiting that might improve relapses for NMO patients. So this single center phase 1b study was open label, and C1 esterase inhibitor was used in NMO patients experiencing an acute relapse. The key inclusion criteria included a diagnosis of NMO or NMO spectrum disorder, and these patients did have to be antibody positive. And the patient had to have MRI evidence of a relapse, meaning a gadolinium-enhancing lesion affecting either the optic nerves, the brainstem, or the spinal cord. These patients were treated with 5 days of IV methylprednisolone, and on days 1, 2, and 3, they also received 2,000 units of C1 esterase inhibitor. Patients who did not respond were then transitioned to Plex therapy, and those patients also received C1 esterase inhibitor again after their second and their fifth exchanges. As a phase 1 trial, the primary endpoint was safety, but they also did some efficacy analysis specifically looking at disability reduction. This trial enrolled 10 patients, 7 of whom presented with acute transverse myelitis, and 3 patients who presented with optic neuritis. No serious adverse events were detected, and no related lab abnormalities were found despite treatment with the C1 esterase inhibitor. The median EDSS at admission was 4.5, and this was reduced to 4.0 at discharge and 2.5 at 30-day follow-up. And all but one of the patients returned to their pre-attack EDSS, and only one of the patients required Plex therapy. So C1 esterase inhibitor appears safe based on this data, but we need to keep in mind that the study was not powered for efficacy. However, the efficacy data does appear promising, but keep in mind that it was an uncontrolled study with a small sample size. Larger randomized placebo-controlled trials are needed to better estimate the effect of this potential new treatment for NMO relapses. Again, will this study influence your clinical practice? Please rate between 0, no change, and 100, it absolutely will change my practice. And I'll conclude today by discussing this abstract, which is the analysis of the treatment of neuromyelitis optica at the University of Pennsylvania, which comes from Dr. Jose Torres in Philadelphia. So this was also a retrospective study that compared their experience with 4 immunosuppressive NMO treatments. It was a single center study, and telephone follow-up was used if necessary to gather additional data. So the key inclusion criteria were that the patient carried a diagnosis of NMO or NMO spectrum disorder, and that they had been treated either with rituximab, azathioprine, mycophenolate mofetil, or cyclophosphamide. In a pre-post analysis, these patients treated with rituximab were found to have a median annualized relapse rate reduction of 78%, which was significant. Azathioprine patients had a 39% reduction in the annualized relapse rate, although this was a non-significant finding. Mycophenolate mofetil had a 63% reduction in the annualized relapse rate, which was significant. And cyclophosphamide had a 29% reduction, and that was also non-significant. In terms of looking at the post-treatment median EDSS, rituximab patients moved from a 7 to a 5 on average, which was a significant finding. Similarly, azathioprine patients moved from a 7 to a 6, also significant. Mycophenolate mofetil patients actually had a trend towards worsening, although that was non-significant, and the cyclophosphamide patients stayed the same. So based on this data, rituximab appears to be the most effective treatment in terms of annualized relapse rate reduction and disability progression. However, this study was retrospective. It was a non-randomized study, and also no attempt seems to have been made to match the samples. So we have to keep in mind that the quality of the data is somewhat questionable. Finally, will this study influence your current practice? Please rate 0 for no change or 100 for it will absolutely change my practice.
Thank you, Devon. Very interesting information in a tough to treat condition. I'm wondering what you start the first time you meet an NMO spectrum disorder patient, what treatment do you generally choose?
Probably my go-to treatment initially is often azathioprine, and I use that for a variety of reasons. One is that it's relatively safe compared to some of the other options that are out there for NMO. Another reason is that I've actually had pretty good luck with it in terms of treating my NMO patients. And a final reason is that it's cheap. As you know, there are no actual medications approved for the treatment of NMO. So sometimes it can be hard to get payers to approve expensive treatments like rituximab, and you don't usually want to delay in getting these patients started on treatment. So I often like to start with azathioprine.
Thank you.
Devon, I wanted to ask you a clinical question as well. Once you start a patient on treatment, how do you monitor them? Do you use serial MRIs, or is there some other way of clinically monitoring NMO patients for efficacy of medications?
Thanks for that question. I don't think that the role of MRI is as well defined in NMO as it is in MS, where we use frequent serial MRIs to look for subclinical disease activity. I think that in NMO, patients who are having ongoing inflammation are a lot more likely to present with clinical symptoms that indicate to us that the treatment is not working. So I don't consider MRI to be as important as with MS, but I do follow the patients closely from a clinical perspective, in particular keeping an eye on how often they're having relapses and to what degree they're recovering from those relapses, and trying to decide if I should change them to a different therapy.
Thanks, Devon, for your comments.
Thank you.
In this section, we'll be talking about MS treatment in the oral agent era. My panelists are Dr. Daniel Ontaneda, Dr. Mary Rensel, Dr. Devon Conway. Dr. Rensel will lead us through a discussion of this topic. Mary?
Okay, so at the CMSC this year, recently in Dallas, many have you've given us many studies on issues related to oral medications. So we're going to focus on the MS treatments in the oral era. How are things stacking up? Okay, we'll start with fingolimod, our oral medication that we've had the longest. It's been on the market for approximately 4 years. The title of the abstract was Fingolimod Effect on Relapse Rate in Young Adult Patients with MS. Dr. Carlson from Switzerland was comparing the annualized relapse rate for fingolimod versus placebo and fingolimod versus the intramuscular beta 1A in young adults from previous phase 3 studies, both the Freedoms and the Transforms. First of all, they looked to see what age patients were in both of these trials, and less than 3% of the patients in either Freedoms or Transforms were less than 20-year-old. And then about 27% of the patients were less than 30 years. What they saw across all of the data in both of those studies was that the annualized relapse rate was low in all the fingolimod-treated patients across the board in all ages. They did notice that there was a stronger treatment effect of fingolimod versus placebo and fingolimod against interferon beta 1A, and those treatment effects were higher in the younger adult patients as compared to overall all the patients with all age ranges. The annualized relapse rate in the control group of the younger patients were higher than what was seen in the older patients. And to evaluate this in a larger randomized double-blind study for younger patients ages 10 to 18, this data was used to predict the sample size that would be needed in a study of young pediatric MS onset patients. So they've decided they need approximately 190 patients for a study that is currently enrolling called Paradigms, looking at oral fingolimod in pediatric onset MS versus interferon beta 1a. Some takeaways from this study is that the study called Paradigms is now recruiting, so we have the first time that pediatric onset MS has a double-blind controlled study. It's an international study, so this is exciting for our pediatric onset MS community because there hopefully will be more information for these patients and their families. We also saw that pediatric onset MS may be more clinically active at younger ages, and we do need further information on the efficacy and the safety of these disease-modifying therapies in this age group, the pediatric onset MS cases. So will this study influence your current practice? 0 for will not change my practice at all, and 100 for absolutely will change my practice. I'll give a little opinion on this. You know, we need more information on this. We won't know yet if fingolimod is effective in this age, the younger age, the 10 to 17-year-olds, but there's some suggestion that fingolimod was more effective in the younger age cases. The second abstract we're going to look at is called The Incidence of Relapses During the First 6 Months in a Cohort of Patients Switched to DMF or Dimethyl Fumarate. Dr. Hillman of the University of Washington in Seattle decided to look back at patient characteristics that would predict relapses in the first 6 months of DMF. Records were reviewed of patients who required rescue medication for a relapse in the first 6 months of DMF therapy. What they found in their data was that most of the relapses occurred in females ages 30 to 40 and in the first 3 to 4 months after the switch to DMF. They also found that there was a higher risk of a relapse if the most recent medication used was the natalizumab. And there was some discussion in the abstract that with the DMF, we may not see the full clinical efficacy of it for about 6 months. So in the abstract, there was some suggestions to counsel patients when you change medications and discuss with them the risk that it is possible to have a relapse when changing medication. Especially in this abstract, it suggested that women in ages 30 to 40 years and if coming off natalizumab may be at higher risk to have relapses after stopping natalizumab and going on to DMF. Takeaway from this study is that we may want to consider a crossover where we continue medications for a while when we start a new medication, such as the DMF. We also may want to counsel our patients like we talked about, maybe just counsel them to the potential risk of a relapse and to be in touch with their neurologist if they feel like they're clinically changing. So will this abstract change your current practice? 0 will not change at all. 100 absolutely will change my practice. The next abstract is titled The Early Adopters of Tecfidera, Preliminary Characteristics and Patient-Reported Outcomes from the NARCOMS Registry. NARCOMS is a North American registry of MS patients, 37,000 enrolled MS patients. They have a questionnaire when they are enrolled into this registry, and then they have semi-annual questionnaires. Dr. Cofield here reported and compared groups of DMF users based on their current and their past treatment history. And they included responders to the fall updated survey of 2013. DMF was approved in April of 2013. And they included in this abstract people who actually filled out the questionnaire, and amazingly there were 8,284 responders. Out of those responders, the patients were predominantly female, predominantly white. 14% were diagnosed within the past 5 years. What they noted in their abstract and in their findings is that the users of the DMF were typically younger, meaning younger in age, and also their length of disease duration was shorter. 5.5% of the patients that completed that questionnaire have either tried or still on the DMF. There was a higher adoption rate if they were younger, and there was a higher adoption rate if they didn't have MS very long. The current and the past users had very similar demographics otherwise, and they did not see a change in their disability progression on a PDSS between the users of DMF and the non-users of DMF. So a takeaway from this study is that we may find that our younger age patients and our lower disease duration patients are more willing to try new MS medications. So will this study influence your current practice? 0 will not change my practice at all, and 100 absolutely will change my practice. Another abstract that was reviewed was delayed release dimethyl fumarate as add-on therapy to interferon beta or glatiramer acetate in relapsing remitting MS, the safety and tolerability. Dr. Colquitt and colleagues from the Shapiro Center for MS in Minneapolis sought to describe the safety and tolerability of DMF as an add-on therapy to either interferon beta or GA in a phase 2 open label study referred to as EXPLORE. The patients all had clinically definite MS, and what they did is they stayed on their interferon betas or their GA for 2 months at least, and then went on as well DMF 240 milligrams TID for 6 months. The safety profile of these two groups of patients of the DMF was the same as that seen in the phase 3 trials of the DMF. The most common adverse events were flushing in 42%, diarrhea in 32%, and abdominal pain in 21%. All the adverse events were mild to moderate. There was no increase of infection. There were no reports of malignancies. They did note that the week 24 mean lymphocyte count decreased by 22% in the group that was on both DMF and interferons, and only by 7% in the DMF and GA group. There were no deaths. There was a slight transient increase in the LFTs. And the conclusion was the safety profile of the combination of the interferon and GA with the DMF was similar to what was seen in the DMF trials. So the takeaway from this trial is that patients tolerated the combination of these medications with DMF for 6 months similarly as they did in DMF alone. We may want to use this information to consider covering patients as they start the DMF to decrease the risk of the relapse. We may want to ask them to continue their injectables for a few months. In this study, they continued it for 6 months, and we could consider them staying on their medications for longer. Will this study influence your current practice? 0 will not change my practice, and 100 absolutely will change my practice.
Thank you for that interesting presentation, Mary. I have a question. As somebody who sees both children and adults, do you find that your children tend to be more clinically active? And how do they usually react when they have to go on to an MS disease-modifying therapy?
We do find that the young onset of MS do have relapses more frequently, and the brain MRIs tend to have more inflammation. The lesions tend to be more impressive. And you know, their reaction to going on medication is similar to what I've seen adults' reaction. They're surprised, they're not sure they can do it, and then with some assistance and some support, they're able to tolerate various medications. There have been tolerability studies in some of the disease-modifying therapies that have been proven in adults, but there haven't been any nice double-blind or placebo-controlled studies in pediatric MS yet.
Mary, I also have a question for you regarding that last abstract. So when you're switching a patient off a disease-modifying therapy, especially maybe one of the injectable medications, is it your clinical practice to continue them on that medication while they start up on dimethyl fumarate or not?
It is not my clinical practice right now. There was a time when new medications came out. We said, well, maybe we should put some space between the medicines, and we've stopped doing that. We don't do a washout period anymore. We have had a few patients have relapses during the transition time. And when you're in a clinical visit with a patient and you're reviewing all the possible side effects and why we're changing medicines, I think one other thing I've been trying to add to make sure I tell the patients it is possible to have a relapse when we change the medications. I'm getting a little closer to potentially, you know, having them stay on other medications for maybe 3 months or so, because I have seen a few relapses during the transition times.
Thanks, Dr. Rensel, for your comments.
Mm-hmm.